Good afternoon. Thank you for attending this month's Ocean Grand Rounds. I am your host, William Pinnock, and today I could not be more excited to welcome back Dr. John Heintzman of Oregon Health and Science University as he presents on Preventive Services in Middle and Older Age Latinos, the Past Due Study. Dr. Heintzman is a board-certified family physician, health equity researcher, and practicing community health center clinician. He received his MD from Temple University in 2002 and completed his residency in family medicine at Oregon Health and Science University in 2005. He received his master's in public health from Portland State University in 2011 and master's in clinical research from OHSU in 2017. He directed the OHSU Family Medicine Postdoctoral Research Fellowship in Family Medicine from 2017 to 2020. Dr. Heintzman started his research career formally with a Career Development Award from the Agency for Healthcare Research and Quality in 2012 on delivering preventive services to Latino immigrants in Oregon community health centers, and this portfolio has continued to grow as he has partnered with Dr. Miguel Marino on multiple NIH-funded projects examining Latino primary care equity in the health center setting. He has served as an affiliate investigator and as scientific leadership at Ocean, and he is currently a dual PI of the Advanced Clinical Research Network and co-chair of the Patient-Centered Outcomes Research Network Research Committee. He currently co-directs the Primer, the Primary Care Equity in Latinos Center, with Dr. Miguel Marino. This session is being recorded. Attendees are muted upon entry, so please pose your questions through the Q&A or chat box. This presentation will last approximately 40 to 45 minutes with 10 to 15 minutes at the end to answer any questions you may have. We will now pass the mic to Dr. John Heintzman for Preventive Services in Middle and Older Age Latinos, the Past Due Study. Dr. Heintzman, the floor is yours.
Thanks, William. I'm going to share my screen here. Hopefully everyone is seeing so everyone can hear me and see my screen. And William, can you confirm?
Yes.
Great. Well, good afternoon, everybody. Thanks for Ocean for inviting me. Thanks for that introduction. As Will said, my name is John Heintzman. I'm a family doctor at OHSU, and I work at Clackamas County Community Health, which is an Ocean member. I'm also an affiliate investigator here at Ocean, and I'm really excited to be talking to you today about our project Past Due, which dealt with preventive services in middle and older age Latinos. It was funded by the National Institute on Aging and just wrapped up in the past year. Presenting on behalf of my kind of center co-director, Miguel Marino, who is also my kind of long-term thought partner. He is on paternity leave currently, so he can't be with us here today. But on behalf of our center in general, and I'll talk briefly about that here at the end. But obviously a big team that was on this. Some of these folks, a lot of these folks from OHSU, a lot of these folks from Ocean, and partnering organizations. A lot of work. Many hands make light work, and so that was certainly here, and I am indebted and grateful that A, to work with these people, and B, that I get to be the kind of representative of a lot of great thought and work. And so just thanks to everybody here who contributed to this study. And there's some acknowledgments of folks who are significant groups: OHSU Family Medicine in general, and the Biostats Division, our funder, NIA, Ocean, of course, and the Advance and Collaborative and PCORNet networks that were just kind of played key infrastructure roles in what we're going to talk about today. So this is a project that looked at prevention in general in Latino older adults in our network of community health centers. It's worthwhile spending a little bit of time talking about kind of the national context of Latino healthcare, especially around chronic conditions, things that we would actually talk about prevention for. And that context is a little bit complicated and varied. So, for instance, and this is from the CDC. Well, actually, let me just kind of, before I dive into this, one aside. You will see the terms Latino. We'll use Latina, obviously, when it's appropriate. You'll see Hispanic. You'll see Latinx, probably sprinkled throughout. The Latino and Latina scholars and the team lead a discussion about terminology. We generally use multiple terms, allowing that they're not necessarily mutually exclusive, but try to give deference to the folks who choose to describe themselves in certain ways. And so you just the upside of that is you will see both terms sprinkled, or multiple terms sprinkled throughout, and we can talk about that certainly later. But among Hispanic and Latino folks, overall mortality from big causes, heart disease, cancer, is lower. But when you dig deeper, it's not that straightforward. So, for instance, the incidence and complications from diabetes in Hispanic and Latino individuals is significant, and significantly more than white individuals. End-stage complications for a variety of diseases, especially around liver and kidney disease, are much worse in Latino patients. And even if you dissect, for instance, take that cancer, if you look at either specific cancers or recent data about late-stage diagnoses and screening rates and things like that, that it's not always that straightforward, and then there are significant disparities for long-standing ones and evolving ones in Latino communities in the United States. But relevant to primary care, obviously, we're concerned about prevention and screening for some of these common conditions. And indeed, in screening, and this is just kind of a sampling, there's also a similarly mixed picture. So this is just National Health Interview Survey data that looks at just rates of kind of in the past couple of years, did you get the screening test? And so, and kind of not, breast cancer, Hispanic Latino women, less likely to have had a recent mammogram, more likely to have had a PAP in their last 3 years, but then adults of age, Latino adults of age, less likely to have any kind of colorectal cancer screening test. And so not necessarily consistent across cancers or across preventive areas. Now, I would tell you, I would confess to you as a family physician, I am who talks about these things with patients frequently. I am suspicious of sometimes survey result data, not because it's not great science or amazing people who do this work, not at all. But what I don't know, well, I'm suspicious for a couple of reasons. Number one, I'm always suspicious of just research that stops at, did you get this in the last 2 years? Because I always think about, as I've gotten to know patients, prevention is often over time. It's an ongoing conversation with people. It is services delivered repeatedly at intervals, et cetera. But there's another thing that's always kind of stuck in my craw, and I bet if you take care of patients, you think this, you kind of know this too, or even if you are a patient, frankly, that people don't really actually remember what they've gotten or when. It doesn't matter what group. This is a kind of an old paper that looks about 15 years ago, looked at Medicare beneficiaries and looked at the agreement between, if you ask them what service did they get, and then looked at the claims data, Medicare claims data, to see what they didn't remember correctly, and they actually over-remembered most times. So they would report they had something in a given interval or ever, and they actually hadn't nearly as much. I was reminded of this. I was at my family physician, my family physician a couple of years ago, and he was drawing blood for something, and he's like, "Hey, well, we want to check your cholesterol," and I was like, "No, I think I had that like last year." He's like, he looked at the record, he's like, "Or 6 years ago, you had it." So people don't remember, and so I think there's this space, and that our center and our team wants to look at the record and see what really has occurred over as long of a time period as we can get to see how services are delivered. And so in that space comes the fundamental question of this project was, in community health centers, do middle and older age Latino patients receive or utilize preventive services equitably compared to non-Hispanic white patients? And I'm going to go in to kind of break that question down a little bit more. This was I'll also just confess, this was our our team's first foray into preventive care. We had a project on asthma prior to this, and we really felt like we were interested in prevention broadly, which I think you'll see in the presentation. We really cover kind of a lot of ground broadly, and there's a lot of room for more depth. But as you ask questions, you uncover more questions. But this is what we were really interested in, looking at broad prevention for common conditions. I think it's also worth spending some time on our kind of outlook on this. The next couple slides are these kind of like mock-up models about kind of the delivery of care and how disparities work in primary care. And the details may not be, and these are kind of like in-process diagrams that we kind of think about and use. the point of them is the following, that if you think about something like a preventive service, from beginning to end, and there's multiple different steps. And if you're talking about equity and disparities, those things can show up at any of those steps, and they may show up for different reasons, or the same reasons, or people may have a good experience with one aspect of that cascade, that continuum, and not a good experience, or not a effective experience with another piece. And just so that all those things can kind of we need to think about primary care not as just one process, but multiple processes. I mean, this is a similar thing, just thinking about all the things, the social determinants of health, the things that weigh in and that might affect or impact or be associated with equity or disparities, or mitigate those things, that they could act on several different spaces, points of the continuum. And we have that lens in the work we do, where at times we're really breaking things into stages, and I think you'll see that. However, we also think that's kind of a zeroing in. We also back up and understand the concepts that I think many of us are familiar with about the social determinants of health and these larger factors that weigh in on those individual steps. This is from the World Health Organization, kind of a conceptual model that we use. And I actually think this diagram is probably needlessly complicated, but the point is there's all of these factors that can be grouped in multiple ways that end up impacting well-being. And so our approach is looking at the individual steps of primary care, but also considering these larger factors that may weigh in on those individual steps. And so here were our aims. And for those of you who are familiar with aims pages, you kind of you write out in the research proposal, you write out the original aims. And the reality, I know on our work, is all of these kind of interweave. You don't do one, then two, then three. You kind of do them all at the same time. But essentially, we're looking at comparing Latino patients to non-Hispanic white patients in their use of preventive services over, I'd say, 10 years, as long as we could. And I'll talk about that a little bit. And then looking at the individual and community level social determinants of health that might be associated with completion or effectiveness of those, or completion really of those preventive services. Age 60, that's a little bit arbitrary. We chose that, well, a couple of reasons. It was funded by the National Institute on Aging, and so we wanted to look at an older population. But we're generally interested, that cutoff, there's nothing magic about that cutoff. We were interested in kind of older adults past middle age. You'll see we kind of cheated when we got to the study. We actually kind of cheated back a little bit and looked at folks in their 50s, just because it was necessary for an individual for analyses. You kind of the arbitrariness of the 60 in the proposal really kind of reared its head, and we had to look at people slightly younger too. So for practical reasons, but this is the direction that we were going. For those of you who are familiar with Advance, which is the research network of which OCHIN is a part, that has this kind of common data model. At the time we did this study, this was OCHIN, Health Choice Network, and Fenway Health in Boston. And these are some of the elements that we have in that data set. This was the map of at the time specifically of the states and where we had where the patient population came from. And this is kind of the nuts and bolts of the study. We had about 145,000 Latino patients and about 250 non-Hispanic white patients. We backed the age up when we started the study to 50 and over, just to capture people going into that older age group. And at least one visit in between 2012 and 2017, has to do with we had more data than that. We had data on patients before and after that, but they had to actually have a visit in there just because of the way the data warehouse was structured. So that was kind of an inclusion criteria, but we often had more than 5 years of data, depending on the specific analysis. And then we often, this differed a little bit analysis to analysis. But the frequent common comparison was when we looked at Latino and patients versus white patients. We broke Latino patients into Spanish preferring and English preferring. That field is relatively robustly filled out in the OCHIN data in Advance. Not a lot of missing data there. And we do that for two reasons. Number one, language is obviously a potential barrier It puts practical barrier in the delivery of care, right? It affects the care processes. But if you read Latino healthcare and health equity literature, folks who are Spanish preferring and English preferring may be just different groups of folks. You know, whether you're talking about recent immigration or less acculturated or lots of different concepts you can overlay on that proxy. But they're often viewed as slightly different populations with different circumstances, and so that's actually common to do. And then we looked at outcomes that were relatively common, you know, the things that we spend a lot of time in primary care doing every day. So diabetes, cholesterol, some common vaccines in older adults, common cancer screenings, some infectious disease screening, and then tobacco assessment and treatment. And then we would kind of control and adjust for other additional demographics, comorbidities, you know, common diseases that are relevant to a specific outcome, and then other basic utilization. So people who were in the clinic more or less, and whether that was associated with their use. Now I'm gonna actually do some spoiler alert things here, because when we look at this, you know, we were interested in a broad array of preventive services, and rather than just kind of rattle through a bunch of figures, which I'm kind of gonna do in a couple slides, I want to give you some thoughts to some concepts to think about as you're looking at them, because we cover a lot of ground. That was our intent. Is a little bit breadth versus depth, but and we can and I want to give you some things to think about. But I wanted to actually talk about the limitations of when we did this work, when we do this work, some of the things that we have either trouble doing generally, or sometimes even when we want to, we can't. So when you're looking at preventive services, sometimes it's challenging to figure out who is due for a service. Now, if you have enough people with enough data and enough in the age range, and you have some diagnoses like surgeries they've had and other diagnoses, you can make some reasonable estimations about that this group of people should be due for a service, and it should be about the same as another group. But still, as you could imagine, especially if you're clinically trained, you know, there's things that you may not capture in discrete data in the EHR, you know, situations that would affect who is due for service, outside data, things like that. So you can't always nail that down in every individual for certain. Limited results data. I'll give you an example. So sometimes, as you may, in our ambulatory health record, we can see an order for something, but if that goes out to a partner organization, that may or may not filter back in to the OCHIN electronic health record or advanced health record in a way that we can catch. For instance, in past due, our breast cancer screening analysis had to just focus on mammography orders. Now that's, if you think back to those kind of flow diagrams, it's still an important step. You have to have it ordered before it's done, but obviously not comprehensive. That's changing. A lot of that result data is now actually starting to be present in the EHR, and we're working on some stuff. But sometimes connected data that would stem from a connected organization wasn't present, and we did what we could. Screening cessation. I had high hopes to look at, you know, what happened when people stopped screening. So when they're latter part of their 70s or early 80s, who still got screening tests for certain things. Turns out we just didn't have enough numbers that in OCHIN, at least at the time, or in advanced data specifically, the numbers of patients fall off pretty rapidly after 75. And we just didn't have the bandwidth or have the power to do that. We're just scratching the surface on two things that we really wanted to do more of, and are doing more of in subsequent projects, but in past due, you know, understanding the community level data that we could link to the electronic health record data through address, just getting started, and also data disaggregation. I'll talk more about this a lot, but the idea that Latino patients are not homogeneous by any means, and wanting to, you know, one step is by language, obviously, but there's other more granular categories that is probably really important for us to understand, and their, you know, association with healthcare use. And so that's something we just scratched the surface with in past due. The final kind of limitation that, you know, we use non-Hispanic white patients as comparators. Now, conceptually, in the past few years, that's been questioned, and justifiably so. As always, you know, referring everything to white patients, it can be kind of have a white-centric feel to it, and that's a justifiable concern. It's still depending on the research question, and the statistical approach is actually is still a tool to use, and we used it here quite frequently. But I think the practical problem when looking at studying community health center patients is white patients in community health centers aren't necessarily doing very well either. And so you're comparing to a group that may be not doing well. And that has to be considered. And we've even started to explore that more. Like what really is this as a comparison group? And so this is important to keep in mind as you think about these results. And so I wanted to talk about then the themes. What themes did we see? Because I actually want you to kind of have these in mind as we go through. Now, 2 comments. I'm a generalist by training, and I'm a lumper, not a splitter. Like I like to look for unifying ideas. That's not the right way to do it. That's just how I do it, and that's how I think we did it a lot in this. As I look at across a lot of the analyses and manuscripts and papers we wrote, what are the big picture themes? Not everything I show you is going to map to one of these. There are certainly other themes that might be kind of that showed up once or twice that are important, but I wanted, because we're kind of covering a lot of ground, I wanted to give you some themes, some bigger picture themes to kind of noodle on as I talked. The second thing is, if there are folks on the call who work in community health centers or take care of Latino patients, I suspect, I don't know for sure, I suspect that many of you would read these and see some of these findings and be like, yeah, I see that all the time. It might indeed kind of jive with what your real world experience is. It does with mine, in some ways at least. And I would, if that is your thought, the point that I would make would be, because you could ask, well, why do you do the research? We know this. The literature about healthcare, about Latino health equity and primary care does not say these things, not in any great volume. And so I think, we have a seminar series, and we had a speaker last week who was talking about one of his mentors, and he said that she had told him, she does equity disparities work, and that the big part of her job was to document the obvious. And so sometimes it's really important, even if in the practical experience of people, we see these things, it's important to get it into the scientific record for further work to build on those kind of ideas. So here's the 3 themes. Now, so number 1, and what you'll see, I think, in many instances, is in community health centers, our Spanish preferring Latino patients, that group actually often used more care, more services than the other groups in the study, especially when it was, I'm going to use the word point of care kind of with hesitation there, but kind of like the first step in care. And I'll show you what I mean, where something available right in the clinic. But here's the kind of the kicker. Theme 2, despite that utilization, there were instances, more than a couple, where the follow-up step, the services requiring greater coordination, that might have been referrals out, that might have been slightly more complex, actually that utilization drops off. There appears a disparity compared to the other groups that wasn't there in that initial service. And I'll give you some examples. And then the third theme is that English preferring Latino patients in community health centers basically utilize preventive services in a pattern similar to white patients. Sometimes a little bit worse, actually, but often without really a distinction. And we'll talk about, I'm going to give you some examples. I'm going to run through some findings, and then I'm going to talk about, I think, some implications for next steps and what we're working on along these big picture themes. So here we go. So I'm going to run through a bunch of different findings, papers, and try to pull out some of those themes, but show you the kind of things we work on, how we kind of ask these questions, and what we got. So vaccination. And this, I think, this analysis demonstrates some of those trends really, really nicely. This looks at pneumococcal and pneumonia vaccine and influenza vaccine. For those, comparing, the blue is Spanish preferring Latinos, red is English, and that comparison line, that dotted line up and down is the non-Hispanic white comparators. And we looked at all kinds of stuff. So we looked at people at 65 and older. We looked at 50 to 64, the top 3 rows, and had conditions that would make them eligible for pneumonia vaccine. And we looked at odds, we looked at rates, and we looked at, odds of 1 or odds of 2. And in almost all of those things, the Spanish preferring Latino patients got more vaccines, or were more likely to, or had a higher rate. And the English preferring Latino patients either didn't, as compared to non-Hispanic whites, or got less. And you see these trends evidenced here, that at least trend 1 and 3, with these these vaccinations that are often given in the clinic. It's also interesting. This paper the data was from before COVID. We published the paper during COVID. It is interesting to during the time where this was being published, we're working on this and revising it. There was a national narrative around vaccine hesitancy in Black and Hispanic patients, which I think this is it's a big cohort of people. I think this kind of answers that narrative in a way that narrative may not be nuanced enough. But certainly in our experience or our findings here, our Spanish-preferring Hispanic patients or Latino patients were often the ones getting these vaccines, at least. So that needs to be considered in those kind of narratives around vaccines. But we also looked at, we did some work in diabetes. And what I want to do is I want you to not do the best you can, not to pay attention to Model 2 and below. I'll come back to that. I know I've told you not to pay attention to it, so now you're going to read it in detail. But and just look at the top row. And so what we were interested in is one of the basic care measures in diabetes is getting a hemoglobin A1C. It's used to screen for diabetes frequently, more and more really in the past decade, and they used to monitor diabetes. On the left, that's in those with diabetes, how often did they get an A1C? And on the right, it's if it is without, how often did they get it? To presumably to screen. And Latino patients had a higher rate or odds of getting those A1Cs. And the rates, the numbers were around, for those with diabetes, we don't have the actual numbers here, but there's around a couple a year, which is in the ballpark of appropriate, depending on how controlled it is. But the Latino patients more likely to have A1Cs. However, we went further to look at let's pull that apart by language. This is another analysis by Benjamin Aceves, one of our colleagues, to break that out by language and to look at actually what that's driven by is really the Spanish preferring Latino patients getting more likely to have or having a higher rate of A1Cs. And that the left column, the kind of the y-axis there, that always under 70, that basically what that's saying is it didn't really matter how controlled the diabetes was, that still the Spanish preferring Latino patients had higher rates of A1Cs. Also in this analysis, not pictured though, is the idea is the fact that Spanish preferring Latino patients were far more likely to have an A1C above 9. And so you see theme 1 and theme 2 come up here, where they actually receive A1Cs. These are results. They have an A1C value more often, higher rate, but less likely to be controlled. And so there's a no disparity, at least between these groups. And then there's a I don't want to say a breakdown, but there's a change, a difference occurs with more of an end outcome. And I think that supports those themes pretty robustly. But then we also did a bunch of work around cholesterol screening, and as you know, so we geared this around kind of statin therapy. So statins, medications used to treat high cholesterol, cardiovascular risk. They're not the only. That's only one component, obviously, of treating risk for heart attack and stroke. But we because there's so many guidelines around that, we did analyses that kind of had that orientation. And this was an analysis. So we pulled that apart, like we're pulling those steps in primary care apart to see what we could see. And Jorge Kaufman led this for us and looked at a bunch of different groups, but I'll mostly comment on Latino patients, that essentially looking at whether they had all of the elements necessary to make decisions about their risk and statin medications on their chart. As many of you might know, the guidelines for this care had a massive overhaul in 2014. Prior to that, it was all centered around having an LDL measure, a bad cholesterol, low density lipoprotein. After 2014, it was about risk calculations and a risk score, and that had multiple inputs. And essentially what you see here is generally patients of color and or non-English speaking white patients always had these elements on their chart more often than white patients. So these LDL was present, and then all the elements necessary to calculate a risk score for statin use were present more often in those patients of color. But we went farther on that to see if, okay, in these patients, was there a difference across these groups in the eligibility predicted by the things on their chart, and if they were eligible according to guidelines in the study period, did they have a statin prescribed? This looks at 2009 and 2013, when the guidelines were centered around that presence of an LDL, and really kind of used that as not the only, but a primary criteria. And what you see is Latino patients a little kind of more likely to be statin eligible according to guidelines. The English speaking ones are actually not different, right? Not significantly different than the white patients, that vertical comparison line. But then when it comes to those who were eligible, they're actually more likely to get a statin, or to have a statin on prescription on their chart, to be very specific, to have a documented prescribed statin. But then after 2014, there's a couple interesting findings. So you see both Latino groups more likely to be statin eligible according to guidelines at the time. But when among those folks who are more eligible, they kind of went backwards a little bit. Now the Spanish preferring Latino patients still more likely to, but the English preferring Latino patients actually lost any kind of quote unquote advantage as far as their statin prescriptions. Interestingly, Black patients actually were less likely to have a statin prescribed even when eligible after the guidelines, and that was a post-guideline change, which was interesting because the guidelines were revamped partly to kind of address equity concerns, and at least in our sample, that was a little bit less. It may not have happened to the degree that we wanted it to, but you still see in many cases in these last few slides kind of robust testing and prescription of medications. Again, that's not talking about whether folks took medicines, whether they stopped them, anything like that. A lot of questions there, right? Still, but these steps in care more robust. We also did a little bit on infectious disease screening, and the next two slides have some interesting things in common. So these are older adults, remember, and looked at whether the odds of ever having an HIV test on their chart. Now, they don't, right now, I think current recommendations is that everybody gets one at some point in time. And that's the Latino patients were more likely to have an HIV test on their chart, and Spanish preferring Latino patients specifically. I don't think that necessarily matches with the epidemiology of the risk. I'm pretty sure it doesn't actually, but they were more likely to have one. This is not actually, one of the things I thought about. We did not include. So remember, this older adults. So this is not really generally childbearing people. So obviously, that could be a confounder in younger folks. But in older folks, Spanish preferring Latino patients are a little bit more likely to have immigrated, and sometimes every once in a while, folks get HIV in immigration medical evaluations. But I'm not sure that if that's significant here or not. But kind of an interesting trend, and a similar trend. It's not a similar trend, but it's a similar, I think, provocative trend in the sense that this is hepatitis C screening, and looks at there were some guideline changes a decade or so ago that made screening much more universal by age, and so these are all folks who were age kind of had eligibility, were indicated for a test based on their age, and that interestingly, Spanish preferring Latinos were more likely to have hepatitis C testing, or had more cumulative. It wasn't quite significant, but it was basically had a higher cumulative proportion of folks screened over time, over a 5-year observation period, and English preferring Latino patients had less, and which is interesting because I think, and I don't know if Brian Chan's on the call, he's the one who led this, the actual risk is probably flipped as far as who actually we know epidemiologically is more at risk. Again, so that screening, more screening, which is actually not a bad thing. Not sure if it matches the actual risk, but some interesting trends in infectious disease screening. And then tobacco assessment, and another kind of interesting thing. So our Latino patients less likely to be, very slightly less likely to be screened for tobacco, very slightly. But when positive, when using tobacco, had much lower odds of having a prescription for a smoking cessation medication on the chart. Now, there's lots of considerations here. Obviously, we don't capture declinations when a provider offers, or we don't capture those broadly. We don't capture when it's offered and declined. When Latino patients, it's been shown that when Latino patients smoke, they smoke less cigarettes, which can factor into these conversations pretty heavily, actually. But there was a relatively largest group of people. There was pretty significant differences in the presence of smoking cessation medications on the chart. And really kind of coming to the end, close to the end here, we're just looking at cancer, which again kind of shows these very different patterns, some very different patterns, interesting patterns. So in mammography orders, this is what I talked about with, we didn't have the results, but we had the orders. And Spanish preferring Latino patients, much more likely to ever have had a mammogram order. This is women over 50. And then when they had one, had a higher rate. And I think it was about, those rates were kind of, one every 2 to 3 years. But English preferring Latino patients, much less, or less than, not different from whites as far as the odds, but and the rates much less. So a pronounced difference in the Spanish and English preferring Latino patients in the ordering of mammograms. So colorectal cancer screening. So one of the things that's not, I think the triangles here, by the way, are English preferring Latino patients. The circles are Spanish, and sorry for the not labeling. What we didn't show here is Latino patients were much more likely to have the presence of a stool-based test, colorectal cancer screen on their chart in OCHIN patients, or in advanced patients, excuse me. So more stool testing. However, when we looked at endoscopy, they were much less likely to have a referral for endoscopy, including if their stool test was positive, which is obviously troubling. Now, again, one of the problems we get into when we're looking at referrals or orders for these procedures that are probably not, occasionally done in the community health center, probably not, there's a data gap. And so maybe we're just not capturing it, right? That is possible. But it was not clearly documented. And so that would be kind of a worrisome trend as far as colorectal cancer screening goes, although maybe an understandable one for some reasons. And then finally, the last couple I'm going to show you had a little bit of a different angle to them. This, instead of looking at language, this is an analysis done by Estela Vasquez Guzman, one of our colleagues, and it's under review right now, who looked at instead by migrant seasonal farm worker status. So as some of you might know, migrant seasonal farm worker status is an official the Bureau of Labor designation that some of our eligibility specialists, some of our clinics gather that information. They actually gather it in tens of thousands of people across the country. And it's folks who are obviously who are migrant, who are moving a lot, more mobile for work, often agricultural work. And we don't understand a lot about the healthcare utilization of those folks in some respects. In OCHIN patients, among those who had that documented, Latinos who had it documented were actually more likely to have cervical cancer screening and more likely to have HPV done. We're not more likely than the non-MSFW Latinos to have a pap smear, but all the Latinos in the study were more likely to have that than white patients, which is kind of not a new finding. It's interesting. There's a limit to interpreting this. I spoke with an eligibility specialist about this once, and she told me that you have staff with certain expertise will often ask more about this, have the knowledge and experience and relationships to kind of talk about these topics more. And so maybe it's just a factor of clinics who are taking care of a population that has this designation more will then obviously take care of them in certain ways more intensely. But it's an interesting thing, that kind of idea that we're even looking into more in certain ways. And then finally, back to this figure. one of the things that we are doing, and more in subsequent projects, even after past due, is looking at national origin, nativity, things like that. And actually in Ochin, there's a proportion of Latino patients who have that documented, but most don't. About 75% don't. There are almost 85% don't. And so we have been exploring different ways to kind of understand potentially not just what an individual's ethnic origin, but specifically the effects of community. And one of the things, the hypothesis we had is, well, even if we don't have whether someone's Mexican or not, we know if we can look at whether they live in a Mexican neighborhood, not for the purposes of putting an identity on someone. We're not doing that. We don't want to do that. But understanding group dynamics to better inform what data might be beneficial to collect for patients in the future at the individual level, at the clinic, at the point of care in the clinic. All this showed. I'm not sure these findings are profound yet. It showed that basically screening for diabetes, those patients, regardless of the Mexican origin nature of their neighborhood, still had more A1Cs. That advantage seemed to go as far as monitoring. The advantage, not the best word, but there's less difference between white patients in higher percent Mexican origin neighborhoods. I'm not sure I know exactly what to make of that yet. We could kind of hypothesize, but I think the point is understanding, number one, subgroup differences and the effect of neighborhood is really a fledgling science. When we go on to when we were understanding Latino healthcare utilization. So this brings me just to some implications and next steps. So number one, for theme one, I think while sometimes the Spanish preferring Latino patients using more services, I think sometimes that's probably not as good as we think it might be, considering the comparison group. The rates may still be low outcomes, but there is, I think, some evidence at points, even like with vaccinations, of a strengths of community and clinic strengths, and I think that needs to exceedingly in the equity and disparities lexicon be part of our approach to this, and to understand what actually is working. What about the community health center model might connect with Latino communities around certain ideas? What in the communities is a strength that then accesses the care that they need? That approach, I think, is a major theme coming out of past due and needs to be understood more. Obviously, continuing to break down data to different groups and their experience and utilization and health is important in disaggregation. But where does it break down? If there are those strengths that get folks to a certain place or get access to a certain service, where then does it break down into theme two here? What are the biggest barriers to delivering all preventive services and connecting with specialty and ancillary care that's necessary to do prevention? Some that's obvious, insurance, things like that, but you can't refer someone often if they don't insured for colonoscopy. But I'm not sure we understand all of those things. And how and where those barriers successfully mitigated, because they are. If you're a member, I'm sure that you know examples where programs, initiatives where a certain condition we really overcame some barriers to get folks more coordinated care. And so what are the bright spots? And then again, disaggregating that data, understanding different groups and their nuances here is important as well. But then finally, what are the most important salient characteristics of English preferring Latino communities? I mean, a lot of Latino health research is geared towards, as it should be, newly immigrated Spanish preferring folks, but our population our U.S. population is changing rapidly, and there's even more heterogeneity and in English preferring Latino communities and patients that may actually do the same as some of those low-income white patients who are struggling. What is the way to serve that community the best, and how do we understand the heterogeneity in that community, and best deliver preventive services is a new set of questions, I think, that needs to be talked about and done a lot more. And we're working on all those things. That's again, this is kind of one of our foundational projects that really opened up some of these questions. We have 3 projects funded right now. Focus looks at cardiovascular health and specifically the nativity. Frontiers, the same with cancer. Then E-Treat, looking a little more to chronic conditions, diabetes and hypertension, and telemedicine. But it's furthering all of those themes and trying to dive deeper into some of those ideas. And that, I think I am going to end there. This is our center. Feel free to reach out with any questions to our website. And I'm going to stop and open it up for questions.
So thank you, Dr. Heintzman, for that fantastic presentation. And thank you to everyone who attended today's session. Please be sure to visit the Primer Center's website at primerlab.org. That's primerlab.org to read all about Dr. Heintzman, Dr. Marino, and the team's excellent work in this area. In addition, the Primer Center hosts a bi-monthly Latino Health Services Research Seminar, and if you're interested in attending, please contact Dr. Heintzman for details on that great series. And be sure to follow Ochin on Instagram at Ochin Network. That's at Ochin Network, and over on LinkedIn. In addition, head over to ochin.org and advancecollaborative.org to read the latest on our research studies, blog posts, and upcoming events. And don't forget to visit our Ochin YouTube channel to catch up on those past Grand Rounds presentations. And Ochin Grand Rounds will be off for the month of April, but we will be returning on May 23rd with Dr. Rachel Gold of Ochin for her 6th Grand Rounds appearance as she presents on the Building Research in Implementation and Dissemination to Close Gaps and Achieve Equity in Cancer Control, the Bridge C2 Center. Invitations to this presentation will be sent 2 weeks prior to the event, but if you're not on our mailing list and are interested in attending this or any future event, please email me at grandrounds@ochin.org. That's grandrounds@ochin.org. So from all of us at Ochin and Dr. Heintzman to all of you, have a wonderful rest of your day and stay healthy out there.